Welcome to the World Massage Conference.
Hello and welcome to the World Massage Conference. I'm Melanie Hayden. I'm the host for this presentation with Marc Ellis on Bell's palsy assessment and treatments. If you're joining us for the live presentation today, please log into the chat room that you'll see to the right of your screen and log in with your Facebook or Twitter ID. Our presenter will be in the chat room during the live event to answer any of your questions that you might have for him. And just to start, I would like to thank our sponsors, our global sponsor, Massage Envy. When you're happy, so are your clients. You'll find Massage Envy to be a friendly, giving, and supportive environment. Find out about Massage Envy's culture at massageenvycareers.com or like Massage Envy Careers on Facebook. And thank you so much to our education partner, Associated Bodywork and Massage Professionals, provides an extensive array of member benefits and exceptional liability insurance. Visit abmp.com to discover why over 80,000 massage and bodywork professionals have chosen ABMP as their professional association. And thank you to our daily sponsors, Massage and Bodywork Magazine, Massage Today, BioFreeze, and Palm Vital. Bell's palsy assessment and treatment. Bell's palsy affects 40,000 people a year, leaving some of them with permanent paralysis. Find out how to access clients who are plagued with this condition and learn effective methods of treating these people and restoring them to optimal health. You'll discover advanced neurological techniques that can be applied to Bell's palsy or stroke victims equally. Dr. Marc Ellis combines a unique brand of patient care. He started his training in the healing arts while studying the martial arts in 1985. He went on to become a certified massage therapist, chiropractor, and fellow in the American College of Functional Neurology. Currently, he is an instructor at Gwinnett College and an assistant professor of clinical neurology for the Carrick Institute of Graduate Studies. Dr. Ellis developed Neurology Matrix, where he teaches bodyworkers advanced applications that integrate myofascial treatments and neurology. Marc, it's really great to have you with us on World Massage Conference.
Thank you so much. All right, so today we're going to discuss Bell's palsy, and we're going to review what it is, and then we're going to review the neurophysiology that is associated with it, and then we're going to explore treatment applications that are effective for assisting people with Bell's palsy, while at the same time can also help people with strokes as well. So once you have this information, it can be utilized for a variety of different conditions. It's not solo to Bell's palsy. On our first slide, we see that Bell's palsy is a unilateral paralysis of the face. And interestingly enough, this is a ancient mask, and people believe that this was sculpted of somebody who was actually suffering from Bell's palsy numerous years ago. And you can see that they have this unilateral facial weakness. So as we go through, we understand that for Bell's palsy, the risk factors are not completely understood. So when we look at it through a scientific approach, we have not exactly found out what causes it. It's generally thought to be a virus. It's also been known to happen in people who sleep under fans or people who sleep with a window open. And the chances of obtaining it are approximately 25 people per 100,000 individuals. So it's very prevalent in society. It is commonly seen with patients who are pregnant. If you've had a family member with Bell's palsy, a person who's previously had Bell's palsy, and interestingly enough, people with Japanese ancestry. It tends to occur in males and females equally, and the average age of onset is approximately 40 years of age. Peterson in Denmark examined over 1,000 patients with Bell's palsy, and 69% of them had a complete facial paralysis. What we're going to see later in the presentation is that when you have a complete facial paralysis, it's really more severe. People can either present with a complete paralysis of their forehead as well as their face, or they can have a paralysis simply of the lower aspect of their face. All of the patients reported some recovery, but I can assure you that people who have Bell's palsy want 100% recovery. 71% of the patients reported a return to normal facial motor function, which basically means that 30% of the people who have Bell's palsy are not getting a full return, which leaves a very large populace of people who are needing service. And hopefully at the end of this presentation, I anticipate that you will be better prepared to assist these people so that they can go out in public more comfortably, so that when they look at their pictures on Facebook and they're smiling, they can enjoy their smiles. When they see their family photos, they're not constantly looking at, oh, look, my lip is drooping, or they truly have to turn to their good side so that you don't get the angle where they have the incomplete return of their smile or the droopiness of their eyes. It's typically an acute onset, and this is very, very, very important. Bell's palsy tends to come extremely rapidly. It doesn't tend to progress. So what we're going to see is that if a person wakes up one day and all of a sudden their face is paralyzed, that is indicative of a Bell's palsy. If it progresses over time, it's going to be very important to make a referral to a medical neurologist in order to get advanced imaging. There'll tend to be an abnormal ipsilateral tearing or taste or ear pain or discomfort. Now, these findings of ear pain or dysfunction in taste are not always there. It's occasional. A lot of times they just have the paralysis without these other indicators. And the ear pain should be behind the ear, and it should occur just before the onset of facial weakness. So if the ear pain is progressive over time, if it's on the forehead or in the neck or in the mandible, that is not in concert with a typical Bell's palsy presentation. As healthcare providers, it's very important for us to be able to identify when people need referrals to other allied medical professionals. And this is going to be very important for the Bell's palsy client because they may not have had the advanced imaging done. Sometimes people will say, well, it's just Bell's palsy, it'll get better, check in with us over time, and you can have the education to say, no, you know, this did not occur slowly, or it did not occur rapidly, it occurred slowly. I want you to go get a second opinion. And that can be a life-saving decision on your part. So we want to remember those key points. If it progresses slowly, if it's not right behind the ear, these are things that you would want to get a second opinion for. So on this slide, we just reinforce that concept. If it's progressive over more than 1 month especially, this is very, very, very important for making a referral. If there's no return to function within 6 months, then you definitely want to get advanced imaging. And if other cranial nerves are involved, for instance, if there's problems with their eye control or ringing in their ears, or if their trapezius muscle is in spasm, or if their trapezius muscle is flaccid, if they have weaknesses inside of their SCM, all of us as body workers are very, very expert in knowing what the correct tone of these should be. So if you see an SCM or a trapezius muscle that is too weak or too strong and you're treating it, and you know that normally that should improve and it's not, then you want to make a referral and say, I believe there's other cranial nerves involved, and get an advanced imaging. Remember, the SCM and the trapezius muscle are not innervated by nerves, particularly coming out of your spinal column. Those are cranial nerves. So SCM and trapezius are other cranial nerves, and we're very intimate with those. So we want to keep a close eye on that for a patient with Bell's palsy. So in this picture, we're looking at cranial nerve 7, and what we can see is as the nerve is exiting out of the skull, it's going to go and innervate a variety of different muscles. So it'll innervate the platysma, it'll innervate the orbicularis oris, it'll innervate the orbicularis oculi around the eye, it'll innervate the forehead muscles as well. Later, we're going to see that the forehead muscles are under different control than the lower facial muscles. And so we can see very clearly this innervation pattern. It's important to understand what cranial nerve 7 does so that you can accurately monitor the client and make sure that they are progressing as you are hoping they would progress. So here are the things that cranial nerve 7 does, and it's a fairly long list, but I highlighted a couple of aspects that I particularly want you to look at. So you can see on the top section that there's a small area of skin behind the ear that's innervated by cranial nerve 7. Cranial nerve 7 does taste on the tongue. So if you think somebody has a pathology of cranial nerve 7, you can put different flavors on their tongue. Can they taste sweet? Can they taste salty? Things of this nature. Typically bitter is on the back 2/3 of the tongue, which is cranial nerve 9, so it's different. Better to use things like sweet or salty. And then you can see in the yellow section that there are a whole slew of facial muscles that are innervated by this nerve. I highlighted the stapedius muscle, and this is a muscle inside your inner ear, so sometimes the people will have changes in their hearing, and that's because of this muscle, which affects your hearing apparatuses. The other thing that happens in the blue section is that it affects tearing and salivation. So cranial nerve 7 will also affect tearing and salivation. So if you're massaging a client and all of a sudden their eye tears, that means that you're activating cranial nerve 7, or if their eye becomes dry, that means that it's not firing quite as high. And those are parasympathetic nerves. Many of us in the body working fields understand that so many people are in sympathetic overdrive that activating parasympathetics is very good. And you can monitor that through lacrimation and salivation. But in particular and important for a Bell's palsy is to see if these are firing too high or not firing enough. As we look at this, we can see Bell's palsy, and what we'll see is that there is smoothing of the forehead, so that's not always the case. More common is the lower face, but you will see the upper and lower face, an inability to close the eyelid, and drooping of the corner of the mouth. Many, many times the person will only present with drooping of the corner of their mouth, so we want to keep a close eye for that. In this photo, we see the two basic types of Bell's palsy. So the lady on the left, on your left, is able to close her eyes, but you can see that the right side of her mouth is drooping. So she has the Bell's palsy, and she has the type of Bell's palsy that more affects the lower aspect of her face. And then this gentleman on the right side of your screen has the inability to move his face on the left, and you can also see that he cannot close his eye on that side, and he has some weakness of his forehead as well. When a person has this situation, it's very dangerous because they're not able to protect their eye. They can get dust or particles in their eye, and the eye can also become very dry. So oftentimes these people will need to wear eye patches to protect their eye from damage, but you're going to become very expert in helping them to rehabilitate their nervous system so that they can regain function of their muscles so that they can close their eye. And this is really a much more severe situation when you see this presentation here. Many times for the medical profession in these situations, the treatments are corticosteroids. The idea is that the facial nerve as it exits the skull will become swollen, so they give steroids as an anti-inflammatory to attempt to decrease the swelling of the nerve. Sometimes they will do antiviral medications. Other times, particularly say for the young lady to the left of your screen, if they can't get a full resolution, they've actually started to do Botox injections on the good side of their face in order to create a facial symmetry for them. They'll paralyze the platysmus muscle so that they have a facial symmetry. But I think that it's much better for us if we can go through and fully rehabilitate them so that they don't have to do this cosmetic approach. Okay, on this slide, what we're seeing the central and peripheral pathways that are associated with the Bell's palsy. Now, we've discussed what it is, and we've discussed some of its basic approaches. So in this, we're going to look at the neurophysiology associated with what happens, and we're going to understand why sometimes it's just the lower face or the upper face, what it means to us, and get some insight into later on how we're going to approach the care of this client to facilitate health in them. The green arrow is pointing at a blow-up section of cranial nerve 7. And when you look at it, you'll see that that oval is divided into two separate halves, a top half and a bottom half. The bottom half is innervated by only the opposite side of the brain, whereas the top half is innervated by both sides of the brain. So we have another slide that will show us that. So again, here are the two arrows. Those are showing you the pathways coming down from the brain that are going to that cranial nerve, and it has a bilateral innervation. Many of us are used to the idea that the right side of your body is controlled by the left side of your brain and vice versa. In the cranial nerves, this is not always the case. This is one of the situations where there's a bilateral innervation. The SCM, interestingly enough, is also a muscle that has more of an ipsilateral innervation. That is to say that the right SCM is innervated more by the right brain. So if you want to move your left arm and then turn to look at it, your right brain moves your left arm, and then your right brain also activates your right SCM for rotation in that direction, which can be very important to understand for therapeutic applications with your clients. On this slide, we have a close-up of the brainstem activity for the nucleus of cranial nerve 7. So what you're looking at here is the arrow points to cranial nerve 7, and then you can see the descending activities from the brain. So for the one that the arrow is pointing at, you'll see that the brain on the opposite side, which is the darker brown, innervates the top half as well as the bottom half of that nerve center, and the arrow from the same side of the brain, which is more in the mustard color, innervates the upper half of that nerve center, and then it sends out axons to go innervate the face. So that is the general pattern. So when we're looking at it, you're going to have two general types of Bell's palsy. Your first type that we'll discuss is the type that has to do with your upper motor neuron lesion. And your upper motor neuron is the nerve that goes from your brain to tell your body what to do. Those can go to your brain stem, which is where your cranial nerves are located, or it can go down to your spinal cord to control body functions. So when you have the upper neuron lesion, it typically only paralyzes the lower half of the face. So when you look at this picture, you'll see that the lower half of the face becomes paralyzed and the upper half of the face is preserved. The reason that the upper half of the face is preserved is because it's also receiving activation from the same side of the brain. Therefore, it can still maintain function. You'll also notice that the person will be drooling. The reason that they're drooling is simply because they just can't swallow. Even though we discussed cranial nerve 7 dealing with salivation, the person loses their ability to swallow. So in the upper neuron lesion, it's typically only the lower half of the face, and this is a very, very common presentation. When the lower neuron, the lower motor neuron gets paralyzed, what ends up happening is the top half as well as the bottom half of the face become paralyzed. And the reason is that the nerve is damaged after it leaves the brain center. And so wrapped up in that axon fiber system are pathways that are going to both. It really doesn't matter which portion of your brain is activating it or inhibiting it because the damage is in the peripheral nerve. So you'll tend to see upper face as well as lower face. Fortunately for us, if the damage is more physiological or possibly more viral, we are still able to utilize the brain activity and massage therapy in order to get the nerve to heal and grow back. Typically, most people with Bell's palsy recover within 3 months. Many people a year later, though, they will still have it. So fortunately for people with Bell's palsy, these tend to go away. But a lot of people, at least 30% of the people, are left with some sort of dysfunction and paralysis that we want to be able to help them with so that it is better. So let's look at how to examine for facial movement. And basically with cranial nerve 7, it's going to do various things. It will help them smile, it will help them frown, it will help them puff their cheeks, furrow their forehead, and close their eyes. So when you're doing a motor examination of this nerve and you want to say, hey, Dan, how's this nerve working? This is how you look at it. It's as simple as these movements here that you see on this slide. All right. Now we have a little bit more in depth of a reflex. And this is called the corneal reflex. The cornea is the portion of your eye that's covering your iris. The white part is the sclera. So what we're going to do is we're going to stimulate the cornea so that we can see how the input integrates into the brain. And it's important that we make sure that we stimulate the cornea and not the sclera. In order to do this, there's two different ways that we can do this. One is the one that you see here in this slide, where you take a tissue. It's always best to have the client spin the tissue so that it's not the germs of your finger that you're touching their eyes. They're going to look away from you, and you're just going to reach in and you're going to touch their cornea. It's really not the most comfortable thing in the world, but it is important to assess how the nervous system is functioning. If your license for some reason does not permit you to do this reflex, then of course you don't want to do the reflex. Also, in the video that I'm about to show you, there's an alternate method that I think is probably a good way to do it, which is just to puff some air into their eye. So you can either do it by touching the cornea or you can do it with air. And the air is much less invasive for the person. So let's look at how this reflex works. What ends up happening is you touch their eye, and when you touch the eye, the messages go from the cornea and they go down into your brainstem. And once they're in your brainstem, they have a synapse that then goes to your facial nerve. And from the facial nerve, you end up blinking both your eyes. So input from one eye goes into your brainstem, and it has a reaction that makes both eyes blink. So this is very, very, very important. For instance, if a person has a Bell's palsy on the left side of their face, and you test the cornea on the left, they should blink their right eye. If they don't blink their right eye, then that lets you know that the brainstem on the left side is not integrating correctly to move the muscles on the right. And then if you do the corneal reflex on the right side, they should blink the right, but remember the left one is paralyzed. So if the left side is paralyzed, they won't be able to blink it. Now, if you do the corneal reflex on the left and they cannot blink the left eye, but they can blink the right eye, then you go and you do the corneal reflex on the right and they blink the right eye and they blink the left eye, then what that tells you is that doing therapies around the right eye is going to activate brain reflexes that in turn allow them to move their paralyzed side. So this is super, super, super important, because what we're going to do later in the presentation is we're going to discuss the therapeutic applications on how to improve function. And these therapeutic applications are based on brain activity. Remember, muscle tone and muscle function is dependent upon brain activity. Any type of body work that we do, when we make a change in muscle tone, we're actually making a change in spinal cord and brain activity. You can exercise a muscle and increase the diameter of your muscle, and that will increase your strength. But you can also do therapies where you visualize exercising muscles, and you don't actually increase the size of the muscle, but you will increase the strength of the muscle. So this is something that golfers do, where they visualize their driving the ball. This is something that runners do, where they visualize movements before going. So when you change brain function, you're changing muscle tone. And for a person with Bell's palsy, when they have this paralysis, our ultimate goal is to change the muscle tone, but we understand that to do that, we really have to change the neurological system. So one more time, if they're paralyzed on the left and we do the corneal reflex on the left and they blink the right eye but not the left eye, okay, then we do the corneal reflex on the right and they blink both eyes, then we know that doing some sort of therapies around the right eye is going to be beneficial to facilitate neurological function to restore the motion of the left side of their face. Many of you have a variety of therapies that you're already using. In shiatsu, there's a lot of points that we use around the orbit of the eye that are beneficial. When you do different aromatherapies, there's certain aromas that are a little noxious, like peppermints and things, that will make your eyes water or have tendencies to make people blink. So you can be creative with your own art when you see the pattern and you can say, hey, what can I do to activate this pathway? And then you watch to see if you're able to affect the change that you would like. So on the next video, what you're going to see is you're going to see the demonstration of the corneal reflex, and you'll see it with the tissue as well as with the air.
Okay, so when we do the corneal reflex, you can use a tissue, and you're going to spin the tissue like this, and you have to touch their eye. So what you do is you have them do it. So just spin the edge of that tissue for me, please, just like I did it. Okay, now I'm just going to touch your eye. When we do this, we're going to watch to see if both eyes blink or only one. So just look up in that way. And for him, both eyes blink, but this one didn't blink as fast. Then we go to the other side, and we'll do the same thing here. Okay? And both eyes blink. All right. The other way, instead of using the tissue, is you can use something that puffs air. So this is an insufflator. When I push this, air comes out, so you have less concern of germs for their eyes. So same thing, just look up, and you see that that elicits the reflex. And you come on to this side, and that elicits the reflex. And again, when we do the reflex from on his right, his left eye moves slower.
Okay, so to reiterate, what we have is what I was just discussing a moment ago. When you do the reflex, look to see what happens on the ipsilateral and the contralateral eye. On that video, the doctor that we were demonstrating on, when we did the corneal reflex on his right, he actually did not blink his left eye as much. So that shows a little instability in his nervous system that is important to help him with and to benefit him. Okay, now let's look at this. And this is very, very, very important for us, because remember before we said that if other cranial nerves are involved, then you want to refer the patient out. So before we get to the treatment aspect of this, let's look at this very important component, which is cranial nerve 6. So when you're looking at this, cranial nerve 6 is the red pathway, and then cranial nerve 7 is the mustard-colored pathway. And you can see that cranial nerve 7 goes around cranial nerve 6. So if a person is unable to move their eye, where if it's their right eye, they can't look to the right, we become very concerned. Or if they have a paralysis on the left side of their face, if they can't look to the left, we become very concerned. Cranial nerve 6 activates your lateral rectus, which moves your right eye to the right or your left eye to the left. So you can see in this picture, in neutral, the right eye is slightly adducted. When they look to their left, both of their eyes move, and when they look to the right, the left eye moves, but the right eye doesn't. And that's because they can have a tumor in their brain, which indicates the need for a referral to a neurologist. Now, I know that we don't like to think about these things, but it's very important, because as a body worker, one of our responsibilities is to refer people to the appropriate provider if we see something that is not functioning correctly. So as we move into a greater level of service to humanity and to the countries that we live in, what we want to be able to do is, sometimes the other professionals might miss things. So the more educated healthcare providers we have, the better it is for our society. So if you see this, where they have a Bell's palsy, and on the same side they're not able to abduct their eye, then you definitely want to refer them to another provider for further evaluation. So this is very, very, very key for us. All right. Now let's switch into a little different section. So what we're getting ready to do now is we understand what Bell's palsy is. We understand the two main types, where the upper face and the lower face are paralyzed, or where the lower face is paralyzed. We have a good idea of the central pathways that are associated with it. So now what we're going to discuss is a little bit of general functionality of the brain, so that we are able to understand the therapies that we're going to do. So for all brain activities, there's different sensors in our body. So we're all familiar with muscle spindles and Golgi tendon organs and pressure receptors and temperature receptors. And what happens is as we send the messages into the brain, different cells are receiving the input. So if you take someone's hamstring and you rub their hamstring from their knee, and you rub just the same line of skin from their knee up to their ischial tuberosity, you're going to activate one region of the brain. But if you turn around and pull that same skin in the exact opposite direction, you're actually going to activate a little bit different part of their brain. So there's direction-sensitive neurons in the brain. So the same part of skin, if you massage it in one direction, you could get a completely different result than if you massage it in another direction. And when we look at the burgeoning field of fascial therapy, we really gain a wonderful understanding that biomechanically that's occurring as well, where there's a fascial plane going in one direction on the skin, but in the other direction on the skin, there's a completely different fascial plane, and the brain is set up to receive that information. So we see a connection between neurological function and the biomechanical functions. They're completely intimate with each other. There's orientation-sensitive neurons, which is how are you moving your body in space. Texture-sensitive neurons. If you massage a person and you use something smooth, you get a completely different effect on their nervous system than if you use something a little prickly. So we see all different sorts of therapeutic tools, and some of them are a little prickly, some of them are fuzzy, some of them are smooth. And the reality is that each one of those has a different effect on brain activity. And then there's shape-sensitive neurons. So are things curved? Are they in a line? And so the brain is really picking up all of this, and this is the subtlety. This is something that takes your therapies from really great to even greater, is to understand these activities within the system. Now, when you do a therapy for the body that goes in and stimulates brain activity, what happens is those messages go into an area of your brain called your parietal cortex. And your parietal cortex senses input, and it starts from simple, like a single touch, to very, very complex, to where when you feel something, you would say, is it a pen? Is it a pencil? Is it a paintbrush? And what happens is the brain is processing all the input that it feels in the parietal lobe, and then it sends the messages over to the motor area, which are located in your frontal lobe, and it gives it the sensory input that is needed to guide movement. So all ability to move is in many ways dependent on your ability to feel. One more time, all ability to move is dependent upon your ability to feel. So when we want to do a therapy in order to improve movement, we first want to see if the fundamental substrate of movement is in place. And that fundamental substrate of movement is sensation. So on the next 3 videos, we're going to look at a couple of different activities in order to test sensation. So the first one is actually not to test sensation. The first video is just simply to say, as a body worker, we have a wonderful ability that if someone has inflammation and cranial nerve 7. So now we're switching to the treatments for this, okay? So we understand how it works. We got an idea of the brain function. Now, how do we treat it? Well, one great thing to do is to simply massage the inflamed nerve. So you can go in and massage the inflamed nerve in order to generate better blood flow and to decrease inflammation and all the things that we know that massage does. So the first video will just show a basic massage and then a little bit of myofascial coupling of where the nerve exits the skull to make sure that there's no compression there. Then the next video that we're going to look at is single point localization. So this goes into what we were just discussing is, can you feel where I'm touching you on your body? And you'll be very, very surprised if you go and test this on your current clients who are apparently healthy, even high-performance athletes, that when you touch them on their body, they won't actually be able to touch where you're touching. And this is very, very important for stroke patients, people with Bell's palsy, people with dystonias, and you'll see it a lot in them. And then even people as healthy as high-performance athletes. Then the third video that we're going to look at is graphesthesia. And graphesthesia is a more complex function where you either draw numbers or letters on different parts of the person's body. And they have to tell you what you're drawing, and they have to be able to feel it, sense it, understand it, and give you input. This is super, super helpful for patients or clients with Bell's palsy, but you'll find that it's going to be helpful for you with any client that you have. And I would encourage you to just go out and if you take anything from this presentation, start to look at single point localization and graphesthesia on all your clients. It'll only take you a few minutes. So if you have someone with a chronic knee problem, go check these and see, are they able to understand where their knee is in space? And what I would suggest to you is if they're not able to have the correct sensorium of where their knee is or their leg is in space, then they're going to be less efficient at responding to the therapies that you do. And if you do the activities in this video and then go in and teach them, so if they can't feel the number 8, do it over and over and over again till they can feel it. Or if they can't feel where you're touching, do it again and again, and let them open their eyes and touch you 5 or 6 times so that they can feel it and rehabilitate their sensory system. And when you do that, I think you'll find that sometimes, or maybe a lot of times, your massage will become more effective in some of the chronic clients that you have. But we're definitely going to use this for the people with Bell's palsy. So we're just going to look at those 3 videos.
Very important component is the soft tissue massage work for this. So we're just going to do massage on the facial nerve, and then we're going to also look at how it tracks back into where it exits the cranium. So very simply, you're just going to open your mouth. You're going to come on the lateral aspect, and you can really use whatever technique you want and just massage on the nerve. Sometimes pulling it and tractioning is very good. And then if you want, you can go to where it enters into the skull and just do fascial mobilizations in different vectors to relax this tissue. Okay. All right, this is for testing single point localization. He should be able to feel where I'm touching and touch this. So let me have you close your eyes, please. And now he's going to touch where I'm touching you. Good. And use the other hand, okay? Good. 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 Now be inaccurate. Now we'll test the other side, which for him is his harder side. Okay? So this is good. And touch where I'm touching. Good. Okay? Good. Good. Okay. And you can see he's less accurate on this side, so he has a harder time here. Okay? Good. Okay, so this is called graphesthesia, which is can they feel a number or a letter that you draw. So we're going to do numbers. So we'll draw it, and then he'll tell us what number it is. Okay? So you'll be correct here. 6. Good. Confused. I don't know. Okay. What is this? 4? No. 7? Yeah, 7. Okay. 3. Good. 2. Try again. Okay, so he has a difficult time with it on this side. Now we'll check the other side. Okay, ready? Four? Yes, 4. Yes. 8. Good. 3. Good. 2. Try again. 1. No. Try again. 6. Good. As it's more difficult, I'll draw the numbers bigger and bigger. Now, if he were a patient with Bell's palsy on this side, he would most likely be less accurate with graphesthesia on this side. But for him, he actually had a harder time over here. But that's how you would do graphesthesia as a test.
Okay, so we've set the baseline for the sensory test and therapy that we'll use for Bell's palsy. And this slide shows mirror boxes. And the really fantastic neurologist who came out with this information is Dr. Ramachandran. And he wrote a wonderful, wonderful book called Phantoms in the Brain, which I recommend it as a read for everyone. And what he did was he started out with people with phantom limb pains, and he would show them their hand in this mirror box to where if you look at the young lady on the top left of your screen, you'll see that she can see her left hand, and it appears that she's seeing her right hand in the mirror, but they've covered her right hand. So she gets an illusion of her right hand, which teaches her, it tricks her brain almost into thinking, because remember, people who are very, very empathetic, we have cells that are called mirror neuron cells. And what they do is they imitate what other people are doing in the world so that we can interpret how that person might be feeling. So what this does is you're using mirror neuron cells, but you're tricking your own brain in order to think that you're moving a limb that's paralyzed. And so this was first put out by Dr. Ramachandran. So how do we do this in our offices? Well, we just get a little mirror. And with the face, it's a little more tricky because you can't just put your head in a box and look at one side of your face to the other. So we have to use 2 mirrors to create this optical illusion. So you can get one mirror. I just use this small one that you see here. You could get a little bit bigger one if you want, but this one works really adequately, and they're able to hold it up themselves. And then you're going to stand in front of a mirror, or have your client stand in front of your mirror. And what happens is, you can see here with Dr. Fontana that he's standing in front of the mirror. He's covering the left side of his face, which would be his paralyzed side of his face, with the mirror, and he's angling it so that he can see the right side of his face in the mirror that he's holding. So one more time, his left side of his face is paralyzed, and he puts the mirror over it, and then he just has to play around with it so that it reflects the right side of his face, and then he's looking in the other mirror, and he gets an illusion of seeing both sides of his face move. And then what he's going to do is we're going to have him smile. When he smiles, the good side of his face, which is the right side, is going to move for him, but he's going to get an optical illusion that the left side of his face is moving. And when he gets that optical illusion, he's going to activate brain pathways that tell him that the paralyzed side of his face is moving. So this is going to be a very, very, very powerful activation of brain, so that he is able to change those centers of his brain in order to feel like he's moving. Now, what's really important is you're going to be standing on his left, and you'll see this in the video, and you're going to be watching very closely. And when the left side of his face actually begins to move, then you take the mirror that he's holding away so that he can see himself in the mirror. And even if it's only a few degrees, trust me on this, if someone's face has been paralyzed for a year and they've never moved the left side of the face, and you get their face to move 4 or 5 degrees, when you show that to them, they get so excited, and it creates more brain activity. And it says, you know what, brain, that is how you move your face. And their brain pathways begin to remember, relearn, and the correct term is to become more plastic, to create more synapses amongst brain structures that teach you how to move your face again. Then you'll cover it, and you'll do some more smiles or frowns or puffs. You want to figure out whichever thing gets them to actually move. And then when they move, you take the mirror away again, and you let them see it, okay? This is super, super, super important. It creates so much positive reinforcement for them. Now, if you're trying to do the therapy and it's just not happening, then what you want to do is you want to increase sensory input from the left side of their face. So listen close, because this is really key. They're looking in the mirror, they're trying, but you're not seeing any movement on the paralyzed side of the face, which for this gentleman is going to be his left. So what you want to do, if you want to do stimulation, remember, stimulating the parietal lobe sends messages up to the frontal lobe so that they can move. You can really use your own creativity here. So the 2 therapies that I showed you was the single point localization. So you can touch his face and then have him reach over and touch where you're touching, okay? You can do graphesthesia, where you do numbers, and let's say you do the number 6 and they can't feel it. You just tell them, hey, this is a number 6, this is a number 6. Let them feel it. Then you pick like another number, like a 7. They're very different from each other. This is number 7. You do it a few times, and then they'll say, yeah, I feel it. Then you go, this is number 6. They'll do it several times. They'll say, okay, I feel that. Then you say, what number is this? And you draw it, and they'll say number 6. And you go, great. And then you'll do number 7. They'll feel that, and then you have them go to smile again, and you might see it activate. Another therapy that I demonstrated for you in here is just simply to take a toothbrush, which is vibration. And vibration is a very, very powerful stimulator. And you can just use vibration for them in order to stimulate the brain. You could do anything you want. Again, you could do various touch activities, various self-awareness and sensation activities. So we're just going to look at these next two videos, and it'll demonstrate some aspects of this, and I really encourage you to use your own creativity with it.
Okay, so the purpose of this therapy is like the mirror box that Ramachandran developed, but you can't do a mirror box with a face. So we have the two mirrors, okay? And then what the patient or the client is going to do is they're going to smile, okay? And when they smile, they'll see the good side of their face moving, but their brain will think the paralyzed side of the face is moving. So go ahead and smile, okay? And relax. Do you see yourself smiling?
Yes.
Go ahead. Good. You see it moving?
Yes.
Good, good, good. And relax, okay? And go again. Good. You see it?
Yes.
Excellent. So now what that does is that tells their brain that they're moving even though they might not be, okay? So now, if they're having a hard time moving, we can do things like the graphesthesia, or you can take a toothbrush, and I like Oral-B cross action. It vibrates at a frequency that seems to work better than many of the other ones. So what we can do is, he's trying to move it, but I don't actually see it moving. So then what I'll do is I'll do a number. What number is this?
7.
Good. What number is this?
8.
Good. What number is this?
3.
Good. Now he actually feels his face, and he feels it in his brain. Okay. Now smile and hold it there, and they'll see it move, and then you take this away, and they'll actually see that their face moved. So it gives them another level of confirmation that they actually move their face. And relax. Good. And then you can do it again, and you could do a different therapy with it. So for instance, you could use the toothbrush, and you could come here, smile, good, and relax, and you're watching to see if it really moves. Smile and relax, good, smile, and then it moves, and you go, perfect, and you take this away, and you give them the real visual feedback that they actually were able to move, which helps promote the activity in the brain for movement. Good, relax. Okay?
Okay, so once we're done and we go in and we do our soft tissue work in order to facilitate healing in the peripheral nerve of 7, and we go and do the central therapies of single point localizations or graphesthesia or vibration to increase that parietal lobe's awareness of where their face is, and then activates that frontal lobe, then we use the mirror therapy in order to increase plasticity for movement. What ends up happening is we get a client who is happy and smiling. And of course, all of you would know this superstar, but this is good. So, and it's such a joy, such a joy to finish off and to take a person and restore their smile for them. They're able to go out in public and enjoy their friends. It just is a great improvement of their social life. So I would encourage you to begin doing this with people, and even just go think about it, so that way when a Bell's palsy patient comes in, you know, you're prepared. You can do some mock trials with some of your friends. It's like practicing before the big game, and to take this information and to help other people. And, you know, I just appreciate all of you being on here at the World Massage Conference, which is just incredible that we have so many registrants from all around the world. And we really have so many people in the world who are excited and motivated to be of service to others. And my hope and prayer is that you guys would take this information and, you know, make a happier world for other people. So Thank you for being with me on this presentation, and I hope it was a service for you.
Marc, thank you so much. That was really incredibly informative, and you took us through, right from the beginning to really getting a good understanding of what Bell's palsy is, the different types of ways that it can present, and what can be some of the precursors, I guess, to an onset, and then took us right through to some testing and then through to some treatment. And I think you hit the nail on the head when you said, if people can really look at themselves without zeroing in on that one thing, and feeling bad about having their picture taken with their family and with friends and in places that they go, and now you can help them feel good about that again. That just really is absolutely an incredible opportunity for us as therapists, like you say, to really be in service.
Yes, I love it, and I'm excited to hopefully meet and hear people who've used it and got the joy of a hug from a client who they did this for.
Oh, what a life changer! What an absolute life changer this could be. I'm excited about looking at working with this population. I've only ever had one client who has had Bell's palsy, and I guess one of my questions would be, you talked about using these types of treatments as well with people who have had strokes. And do you find that sometimes those can go hand in hand with people that get strokes? Is there a specific frequency that they might get Bell's palsy as well, or?
Well, the Bell's palsy and stroke don't come hand in hand, but the therapies of the self-awareness of where your body part does. So, for instance, I have a young lady that I work with who had a stroke, and she did therapy for 4 years. And when I met her, I went to do the single point localization test, and she could not differentiate the front of her body from the back of her body. So if I tapped her on her forearm and I said, hey, touch me where I'm touching, I did a whole hand, she would touch the back of her shoulder. So she thought that her forearm was on the back of her shoulder, and she couldn't actually differentiate front from back. So when people were trying to do these movement therapies for her, they failed to realize that she didn't even know where her arm was. And as we reestablished her self-awareness, then we were able to teach her to move. And then, of course, if the fascial system or muscle system is adhesed, the soft tissue work is absolutely incredible for getting the movement. But when you couple it with the brain activity, it's super powerful. And then we did the mirror therapies for her so that we showed her, she looked at her right hand moving in the mirror and imagined it was her left, and then she would begin to move her left hand because she knew where it was and could move it. So the stroke and the Bell's palsy don't really go hand in hand, but the therapy does.
Okay, great. That was going to be one of my questions, with this, the mirror box, and is that a standard protocol that other therapists would use, physiotherapists or physical therapists or other types of therapists? Are they already?
Absolutely. It's in the physical therapists are probably the most trained in it. It was developed by a medical neurologist, Dr. Ramachandran, and they use it with people with strokes, and they use it with people with phantom limbs a lot. Yeah, it's out there. It's just, did they learn to do it, and are they effective with it? And, of course, it's not all of them know how, but there are definitely experts in the rehabilitation field that use those. You'll see it all over Google. And really, you can just go down to Walmart and get a big mirror. You don't have to make a mirror box.
That's what I love about that, too. Thank you for sharing that it gives us an opportunity to implement something that's really easy to integrate into our practice right away. Marc, is there a particular time frame that's best to start working with someone? And I'm assuming that there's also, you can start working with someone at any time, even when they've sort of stopped treatment and maybe it's many years later?
Yeah, that's a great question. So in general, Bell's palsy resolves within 3 months or 6 months, but there's no point in waiting, right? So I like to go right away. If they come in and they call me up and they say, hey, because as you build your reputation, that happens. This happened. I like to treat them right away. I don't say, well, let's wait 3 months and see what happens to you. And if they're a year and a half in and they still have paralysis in their face, it's not too late. You go right in there and do it. Now I would suggest if it's a fresh Bell's palsy, that you refer them to a medical professional as well, so that they can do some of those more in-depth evaluations and make sure that it's not something more severe. But I like to go right off the bat and as late as they've had it, years later. It's never too late.
Awesome. Yeah, so that gives us an opportunity to work with the entire population then. Have you ever had people, or is there something that we could keep an eye out for even with clients who might come in that you maybe see some signs of this, like if they have kind of more of a slow onset, and to get them to go to their doctors to say, that's drooping a little bit. Your left side seems to be drooping a little bit. Are you having any other symptoms? Or, is there something that we can kind of look for in advance of someone being diagnosed?
Well, that's a great question. With Bell's palsy, from what we currently understand, it's a rapid onset. So these people one day are running around smiling, the next day they're paralyzed. It happens very fast. If there's a slow progression where you're, looking at a person and their face is getting a little bit droopy, that's a big concern still for a paralysis, but not a Bell's palsy. It could be a tumor, or if it's an elderly person and all of a sudden their face is a little droopy, what you can look up on Google is things for trans-ischemic attacks. Did you get dizzy? Did your speech go off? And when you've treated Bell's palsy patients, you're going to become very acutely aware of observing. It's almost like the first time you palpated a muscle, you couldn't feel the knot, and now you can see the knot, from across the room. Well, you're going to see those signs, and you're going to be able to help people much, much earlier and maybe get them to a medical professional before they have a stroke or before their tumor progresses. The other thing that is really exciting about it is it might not be something so ominous. Their face might not be activating it as much just because their brain activity is not as high as it should be. And you can go in and test these things and do the treatments, and all of a sudden you'll see that facial tone come back. And if you look through a lot of the pictures on Google, you'll see so many people in the Bell's palsy images that you would look at them and never think that they had a loss of facial tone. We're so accustomed to seeing it that we actually don't even always see it. But once you become expert in it, you're going to see it all over the place, whether it's a full-blown Bell's palsy or just a decreased activity of brain.
Okay. Well, that's actually a good point. I think I'm going to, start to pay a little bit more attention when I'm out and about now, and see what I start to notice more closely.
Yeah.
Marc, sorry, go ahead.
If I could add, and when you become really accustomed to this, what you might notice is a client of yours with shoulder pain, but then you look at their face, say their shoulder pain's like, on the right, and you look at their face and it's kind of droopy on the right, you'll start to see it differently. And you'll say, hey, there's something neurologically going on here. And then you go do those sensory tests and you do the treatments, and then their shoulder pain oftentimes resolves just from this. So So you'll start to make those correlations of like, why is their face a little droopy? They don't have a disease, but it's the brain, it's the nervous system, and that's what's affecting their shoulder and modulating their shoulder pain. And you can use this to get results in all different sorts of your clients that you serve.
Oh, thank you. That's a great tip. That's a really, really great tip. And I think just to kind of finish up, how would you suggest therapists go about, if they really want to start working with this population, how do we start to get clients for that? Like, should we go and talk to different physiotherapists who might be working that? Should we, maybe look and see if there's some specialists in our area that are treating that? Or do you have some recommendations for therapists who'd like to start working with this population?
Yeah, I think that it's always a little tricky the first time, that you want to go out and do one, and how it looks like the first time you treat a person with a headache, and then years later you're very comfortable with it. But in this day and age, blogs are really, really wonderful to get the message out, and like you said, meeting up with different physiotherapists is very good. Going and doing lunch and learns for different people, or if you're just doing a body work or event, all of a sudden you're going to start to see it everywhere. It's like you didn't notice how many red Corvettes there were in your area till you bought one, right? So as you start to watch and you're out doing a body work event and you're talking to people about yoga or meditation or stretching, and then you'll look and you'll see it, and then that will open up another avenue for you to ask them, and many of them will go, yeah, but I just didn't think there was anything to do. I just thought I had to wait for it to come back. So as your awareness of it increases, you're just going to see more opportunities to serve.
That's fantastic. Great advice. Really, really great presentation, Marc. Again, I just really love the detail of your presentations. And I see that if people want to get a hold of you, they can get a hold of you at healthybrainnow.com.
Yes.
And thank you very much for sharing the videos in this presentation and the slides in this presentation. So really, really appreciate it a lot, and look forward to sharing this information with our audience.
Yeah, and thank you guys for having me. I think this is just an amazing venue to get out and share with the world. So, I compliment the World Massage Conference on all the work you guys are doing.
Thank you. We appreciate it. It's, we're all a team working together to share and help people get access to really, really great information like this. I'd also like to thank our sponsors, our global sponsor, Massage Envy. Massage Envy is committed to supporting your profession. Massage Envy has donated to organizations that promote the healing benefits of massage and careers in massage therapy. Visit massageenvycareers.com and click on the Giving Back tab for more information. Massage Envy, it's more of a culture than a company. And thank you to our education partner. Associated Bodywork and Massage Professionals provides an extensive array of member benefits and exceptional liability insurance. Visit abmp.com to discover why over 80,000 massage and bodywork professionals have chosen ABMP as their professional association. And thank you so much to our daily sponsors, Massage and Bodywork Magazine, Massage Today, BioFreeze, and Bon Vital.